Hi everyone, I want to talk about vitamin B12 deficiency treatment. B12 deficiency treatment. There are factors to be considered while trying to treat an individual with vitamin B12 deficiency. One, is this pernicious anemia? Because if that is the case, in the next few minutes, you're going to find out how we're going to treat that. Is this malabsorption? Because you need to know, can I go to the oral route here? What is responsible for this malabsorption? Is it post-surgery, short gut syndrome, inflammatory bowel disease, celiac disease, and so on? Is this inadequate dietary intake and no any other problem anywhere? Are there neurological problems? Because it's one thing to have anemia, it's one thing to have neurological problems that is found in vitamin B12. And if that is the case, you're going to see how we're going to handle it. Is the anemia so severe that blood transfusion might be required? You need to make that determination. Can this patient comply with a long-term treatment? Okay, we're going to choose the route, the dosage, the duration, and follow-up frequency. Supplemental vitamin B12 is available in the form of sublingual, per oral, subcutaneous, or intramuscular. Then we're going to treat according to the etiology. First to be considered is pernicious anemia. That is an autoimmune condition. And here, we're going to place the affected individual on long-term treatment. As a matter of fact, lifelong. Pernicious anemia, lifelong treatment. And with that, you can use intramuscular or subcutaneous routes when you're administering the injection. You may give a very high dose per oral, but you will not give that if there are neurological features. Okay? If there are neurological symptoms, forget about per oral. Just go for a subcutaneous or IM. Or if there is acute anemia, or you can't guarantee that the patient will take the medication, it's better you give IM or subcutaneous. You are going to go for as high as 1,000 microgram IM every week for the first 4 weeks. Okay? Then 1,000 microgram IM every month for life. If the causes can't be reversed, okay, like in this case, pernicious anemia, you're going to give like that. You can also give per oral up to about 2,000 microgram per oral once daily. In children, you can give 100 microgram IM or subcutaneous every 1 week, and you'll be checking the value, and until you have a normal value, you continue with 100 microgram IM or subcutaneous every week. But if you have reached the normal value, checking the MCV, assaying the vitamin B12 level and everything like that, then you can continue with 100 microgram IM or subcutaneous every month or once every alternate month. If there is no impaired absorption, then give the vitamin B12 per oral, 1,000 microgram every day, once daily. If there is dietary deficiency only, 1,000 microgram per oral once daily until you have a normal value, then diet rich in vitamin B12. If deficiency is due to surgery with impaired absorption, then you have to treat like pernicious anemia unless the surgical condition is reversed and absorption is no longer impaired. How do we make our follow-up? We check the value every month for the first 3 months. And after then, we'll be checking every 3 months for the next 1 year. How can we prevent vitamin B12 deficiency? We are going to treat associated autoimmune conditions. As a matter of principle, when you find one autoimmune condition, be ready to look out for the rest. So if you find pernicious anemia, check out for Hashimoto's thyroiditis, Crohn's disease, systemic lupus erythematosus, and so on. Let there be good diet to those who are having dietary inadequacy. Include meat, poultry, dairy, seafood, eggs, and so on. You can add vitamin B complex, but it must contain vitamin B12 because that is what you are trying to treat. Cereal and other food items should be fortified with vitamin B12. Remember folic acid if there is also folate deficiency, because macrocytic anemia is not limited to vitamin B12. So know what is happening to folate and treat. I am not treating macrocytic anemia here. I am treating vitamin B12 deficiency, one of the major causes of macrocytic anemia. So macrocytic anemia as a whole is going to be another topic entirely. Differential diagnosis here could involve myelodysplastic syndrome, folate deficiency, I've just mentioned folate as part of it, hypothyroidism, liver disease with encephalopathy, systemic lupus erythematosus, because I've just mentioned if you have one autoimmune, you look for the rest. Uremic encephalopathy, medications like highly active antiretroviral medications. You check if the individual is on azathioprine, methotrexate that is antifolate will lead to folate deficiency and have macrocytic anemia. Gut infections like overwhelming bacterial infection of the gut can lead to impairment or impaired absorption. Chronic alcoholism, inflammatory bowel disease, celiac disease leading to impaired absorption, pancreatic insufficiency, and depression. Depression will affect what you take because they won't even be able to tell when they're hungry or not, and they may not be taking their medications and so on. And of course, dementia could be a symptom and actually could take them to B12 deficiency because they will not be able to follow routine anymore. And dementia could even reach a stage that the affected person will not be able to carry out activities of daily living and instrumental activities of daily living. You can check my presentation on dementia. I have about 7 different videos on dementia, and I've made a separate video on major depression. So when you go through them, you understand what I'm saying better. So I will not waste the time going over that right now. Hypoglycemia, hyponatremia, hypercalcemia will present with neurological symptoms that one can must rule out when you are making the diagnosis of vitamin B12 deficiency with neurological symptoms. So with that, I've come to the end of presentation as far as vitamin B12 deficiency is concerned. Kindly subscribe so that you can get these presentations immediately they are published. Thank you.